Good afternoon, everyone. Today we have gathered here for a very special occasion, the prestigious Dr. Shriodkar Oration, which our society is proud to host every year in honor of great innovator and a renowned surgeon, late Dr. V.N. Shriodkar. On behalf of Solapur Obstetric and Gynec Society, I take this privilege to welcome Dr. Chinmay Ratha Madam for today's prestigious Dr. V.N. Shriodkar Oration. Invited senior members, colleagues, and my dear friends, a warm welcome to one and all. Now I request our President, Dr. Aboli Velankar Madam, to escort our guest speaker, Dr. Chinmay Ratha Ma'am, to the dais. I invite our upcoming President, Dr. Anjali Jamma Ma'am, to the dais. I invite Dr. Archana Shah Madam, Dr. Sudeep Sambaram Sir, to please join them on the dais. Now I request Dr. Aboli Velankar Madam to present the preamble.
Good morning, everyone. Esteemed speaker, seniors, teachers, and my dear friends. It is my proud privilege and an honor to welcome you all for this most awaited occasion of the year in the honor of legendary figure, late Dr. V.N. Shriodkar. Shriodkar Oration was started in 1989. At that time, it happened that a renowned speaker and a practitioner in gynec and obstetrics, Dr. Das Gupta, was called to Solapur to Obstetric and Gynec Society to deliver a lecture on pregnancy-induced hypertension. He spoke on the topic for 5 hours. And the members of the SOGS were so much impressed by his excellent talk, and he gave a lot of information on the topic and was very much appreciated. Dr. V.B. Kulkarni was a student of Dr. V.N. Shriodkar. Dr. Shriodkar had gained international fame with his innovations like Shriodkar sling and circlage. People came from all over the world to watch him operate and admired his operating skills. He was always experimenting and had many innovations to his credit. So, in the remembrance of Dr. Shriodkar and to encourage and continue the education of our members of our society on various topics, they decided to start the Shriodkar Oration. Dr. Ajit Kulkarni was the president during that year. Funds were gathered and an outline was laid and the oration started. We have invited many stalwarts up till now for this oration. Few of the names are Dr. Mamta Deen Dayal on new ultrasound innovations, Dr. Mangala Vani on breastfeeding, pelvic anatomy and uterine transplant by Dr. Shailesh Puntambekar, electronic fetal monitoring by Dr. Bautankar, reconstructive gynecological surgeries by Dr. B.P. Pillai, and Dr. Mradula Fadke on genetics, and many others. Every obstetrician has become very busy in his OPD practice. There is a limited amount of time given to the patient in which we have to take a detailed history, examine the patient, and even give the treatment. Due to lack of proper information and proper protocol, on going about and investigating the patient, we may miss an RH isoimmunized patient. This was the reason to choose this topic, and we have a great orator with an international fame to speak on this very important topic, Dr. Chinmay Ratha. Thank you very much. We'll continue with the Shriodkar oration.
आपण कुठल्याही शुभकार्याची सुरुवात करताना सरस्वतीला नमन करून करतो. तरी यासाठी मी डॉक्टर माधुरी दबडे मॅडम यांना सरस्वती वंदन करण्यासाठी व्यासपीठावर आमंत्रित करते.
चालू केलं
मी वाढतो आवाज
एवढाच बस. या कुंदे नृतुषार हार धवला, या शुभ्र वस्त्रावृता, या वीणावर दंडमंडित करा, या श्वेत पद्मासना, या ब्रह्माच्युत शंकर प्रभृतिभिः देवे सदा वंदिता, सा मां पातु सरस्वती भगवती, निःशेष जाड्यापहा, शुक्लां ब्रह्म विचार सार परमा, आद्यां जगद्व्यापिनी, वीणा पुस्तकधारिणीं अभयदा, जाड्यान्धकारापहा, हस्ते स्फाटिकमालिकां विदधती, पद्मासने संस्थिता, वन्दे तां परमेश्वरीं भगवती, बुद्धिप्रदां शारदां, बुद्धिप्रदा शारदां, बुद्धिप्रदा शारदां.
धन्यवाद मॅडम. I request Dr. Anjali Jamma ma'am to present the life sketch of Dr. V.N. Shriodkar.
Good afternoon, dignitaries on the dais, respected seniors and friends. It is my proud privilege and honor to present the life sketch of great innovator, visionary, hard worker, Dr. V.N. Shriodkar. Vittal Nagesh Shriodkar was born in 1899 in the village of Shiroda, a beautiful village in Goa. The name Shriodkar is derived from village name Shiroda. His alma mater is Hubli in Karnataka. He completed his medical education from one of the best medical college, Grand Medical College, Mumbai. He completed MBBS in 1923 and MD in 1927 from Bombay University. He obtained FRCS from England in 1931. He served as honorary professor of midwifery and gynecology at Grand Medical College in 1940. He used to work for about 14 to 16 hours a day at his clinic at Kambala Hill, Mumbai. He rarely operated without an audience. He gained international recognition and lectured widely, being one of the first to show films of his operations. In 1955, Dr. Shriodkar described the cervical cerclage operation has stood the greatest test of all time. Even way back, he was invited as an international speaker in Paris and Naples. He brought up the concept of incompetent cervix being a cause of repeated second trimester abortions and developed the procedure of cerclage of cervix during pregnancy. Cervical cerclage at the level of internal os to prevent abortions is universally recognized as Shriodkar's cerclage. He realized that catgut was not enough and he used fasciolata from thigh as a suture material. He brought up the concept of incompetent cervix being cause of repeated second trimester abortions and developed the procedure of cerclage of cervix during pregnancy. He realized that, with his engineering skill, he developed instruments for the cervical cerclage. He made numerous publications in many journals. In 1960, he published contribution to the obstetrics and gynecology based on his personal experiences. He made numerous publications in many journals. He wrote in the preface to his monograph, "With all due respects to the masters, I did not reconcile myself to some of the operative procedures, which fell far short of the ideal. Ideas came to my mind for improving the time-honored methods." He was astute enough to realize that his operation was not a remedy for all habitual abortions. He clearly laid down the condition where operation was most likely to be successful and where it would fail. It was just like a musical orchestra to watch him operate. People were mesmerized with his operative skills. Besides being a busy practitioner, Professor V.N. Shriodkar published many books and papers, a keen interest in social medicine. He was a member of the Shantilal Shah Committee on Abortion. He established a family planning association in India and started Dr. Shriodkar's special school for mentally challenged students. The Iron Lady Indira Gandhi delivered Rajiv Gandhi under Dr. Shriodkar's care as he was very well-known international figure, so they chose him for this. He was never happy and satisfied with the routine. He was always in a search of improvised version of surgeries and better outcomes. He had left an imprints for generations to remember. His original experiments are os tightening for implantation of fallopian tube in the uterus after resecting cornual block, creation of new vagina using colon, sling operation for prolapse. These are some less known experiments by him. He was honored by highest awards, Padma Bhushan in 1960 and Padma Vibhushan in 1971. He was an accomplished violinist and keen interest in painting and sports. Such a great man, thinker, innovator, teacher, surgeon par excellence. Thus, multifaceted human being passed away on March 7, 1971 in Mumbai. We will salute him as a pioneer in experimental surgery and gynecology. Thank you.
Thank you, ma'am. Light is considered a symbol of auspiciousness, prosperity, and abundance. Light brings delightness with it and dispels the darkness. I request all the dignitaries on the dais to please come forward for the Deepa Prajwalan, the auspicious lamp lighting ceremony, and to pay tribute to Dr. V.N. Shriodkar. I thank all the dignitaries on the dais from the bottom of my heart and request to please take their seats. Ma'am. We will start with the oration. I request Dr. Aboli Velankar Madam and Dr. Archana Shah Madam to chair this oration. Dr. Aboli Velankar Ma'am. Shriodkar sir. Fast. She is a consultant obstetrician and gynecologist practicing in Solapur for more than 30 years and director at Nirmala Nursing Home. Welcome, madam. Dr. Archana Shah, madam, is a practicing infertility specialist in Solapur for more than 15 years. I welcome you, madam. Over to you, ma'am.
Today I feel so much privileged to carry out the difficult task of introducing our today's orator, Dr. Chinmayi Ratha. She has excelled in many subspecialties, but her mastery in fetal medicine has been appreciated nationwide. She has a charming personality and with great oratory skills, connecting to the audience with ease. Presently, she is the director and lead consultant at Resolution Fetal Medicine Center and Research Institute, Hyderabad. She is a chairperson, National Perinatology Committee, FOXY 2124. She is also a member representative AICC RCOG South Zone. Now, looking to the roots of Dr. Chinmayi Madam, it is one of the factors that defines us. She was born at Behrampur in 1975. Her brother, Shashank Ratha, is BTech, IIT, MBA, and IIM. He is a financial analyst. Her father, Professor B.K. Ratha, PhD Zoology, retired Dean, Science Faculty at Varanasi. Mother, Sanjukta Ratha, BSc Botany, B.Ed, M.Ed, high school teacher, and a board examiner. She has inherited her intellect, which runs in her family. Her husband is an army man, Colonel P.S. Nanda. He is a support system behind her academic career. Here, I want just to share with you a small incident which I came to know, that once during the pandemic, everything was in lockdown, and Madam had a problem with looking after her son at home. She had to stay at home from her duties. At that time, her son said, "No, Mama, you have to carry on your duties." At this time, her husband supported her. He was posted in a different city, but yet he took his responsibility and took their son to his place so that Madam could continue with her work. Her parents-in-law, Dr. K.C. Nanda, retired principal KUS, Mrs. Aarti Nanda, a mother-in-law, a great homemaker, and her lovely son, Ayushman, he is with us today. Dr. Chinmayi loves traveling. Everyone does. but she has actually pursued her passion of traveling with her family, and we know the reason why. Why she likes traveling? Because she has traveled during her education to so many different places. Her childhood and schooling was at Shillong, Meghalaya. What a beautiful place. And at Varanasi, a religious place. She graduated her MBBS from King George Medical College, Lucknow in 2000 and MS from Motilal Nehru Medical College, Allahabad in 2004. She completed her ICMR course in Clinical Genetics, Lucknow in 2006. MRCOG, London, UK in 2009. Fellowship of International Medical Sciences Academy, FIMSA in 2011. RCOG training and trainers course in 2013. Fetal Medicine Foundation US approval as a trainer in India in 2014. These are some of the awards she has attained. Dr. Chinmayi always tried to be the best version of herself. She had the ability to dream beyond her imagination. Her ambition, hard work, and vision made her continue her studies in fetal medicine. She was a trainee in fetal medicine under Dr. Pratima Radhakrishnan, Bangalore, accredited sonographer, Fetal Medicine Foundation, London, attended FMC World Congress at various countries like Croatia, Malta, Spain, France, and Slovenia, Athens, Greece, etc. She has attended online webinars last year, which have helped to maintain the updates in recent advances during the pandemic too. Change is the only constant thing in life, and one is never too old or never too experienced to learn something new. Here, these are some of the pics of her certifications. Opportunities never come often. They come far and few in between. Dr. Chinmayi recognized them and made the most out of them. These are some of the awards she has received. Foxy Rajat Rai Award for Fetal Medicine, Foxy Award for Best Publication, APJ Abdul Kalam Award 2021, Best Oral Presentation Award 2004, Dr. C.S. Don Gold Medal 2003, 8 academic awards to papers presented by her students. आपण म्हणतो की ज्ञान दिल्याने वाढते. She actually followed her passion of teaching and training students. Dr. Chinmayi has a huge work experience. She is presently director and lead consultant at Resolution Fetal Medicine Center, Sikandrabad, visiting senior consultant, Fetal Medicine Yashoda Hospitals, previously lead consultant at Rainbow Hospitals, consultant Apollo Hospital, New Delhi, honorary consultant at a unit in Indian Army, registrar and research fellow at Fernandez Hospital, Hyderabad. She has a great clinical expertise. She specializes in prenatal screening and diagnosis of fetal malformations, genetic and chromosomal abnormalities. She runs the fetal therapy program at her department and conducts treatment for complicated monochorionic twin pregnancies. She has a great teaching experience. She is an FMF approved trainer in India, fetal medicine course faculty and coordinator in Dan, fetal medicine fellowship programs directed at Navodaya hospitals, moderator of RCOG UK MRCOG 2 since 2016, a regular faculty for RCOG UK. She has a satellite classroom teaching for DNB students. She has so many publications, research and book publications. She has contributed to several book chapters. Book chapters like Doppler in Obstetrics, Preconception Counseling of Women with Pre-Existing Medical Conditions, Stress and Immunomodulation in Recurrent Pregnancy Loss, Ultrasound in Multi-Fetal Pregnancy, and Fetal Anomaly Scan. She has been a regular attendee of conferences at regional, national, international levels since her student days. She has been invited at faculty for many national conferences. Currently, she contributes to some international forums in South Asian regions. She has also been a has a professional body membership and fellowships of FMF, UK, RCOG London, ISWAG, FOXY, ICOG, IMSA, and FMFI. So with this introduction, I invite Dr. Chinmayi Ratha to deliver her oration.
Thank you very much, madam, for that very kind and elaborate introduction. I feel humbled standing in front of all of you. The honor of delivering the Dr. V.N. Shriodkar Memorial Oration is really overwhelming. And when I hear the roll call of specialists who have been awarded this oration prior to me, I am really, really humbled for this opportunity. Thank you. At the outset, this is my second visit to Solapur, and I'm really, really touched by the warmth and the hospitality that we have received here. Thank you very much for that, and I'm really thankful for all the seniors and the members who've come here to attend this talk. Now, Dr. Shriodkar has already been introduced, and I am really a very small person to introduce him to the gathering, but I did a little research on his life, and some things which touched me, I want your permission to share them again with you. And this is Steve Jobs who said, "The people who are crazy enough to think that they can change the world are actually the ones who do." And that's exactly how we should describe Dr. Vittal Nagesh Shriodkar, a legend in Indian obs and gynae scene who really changed so much to the way we look at obstetrics and gynecology surgery. Even today, we find it difficult while standing in world forums to put forward Indian surgical techniques. But to think that he did this more than half a century back, I think that was a huge achievement. Let me introduce you to this series, which has been started by the Indian College of Obstetrics and Gynecology, and this is available on the YouTube. This series is known as Diamonds Are Forever, and the first episode of Diamonds Are Forever has been dedicated to Dr. V.N. Shriodkar. Dr. Uday Thanawala, the current chairperson of the Indian College of Obstetrics and Gynecology, has taken this effort of making this. I recommend all of you to go on to the YouTube after today's program, and please go ahead and watch the live sketch of this person. I'll share a few bits with you, because I really thought this was something wonderfully done and something which all of us should know. It should inspire us years after he has finished what he had done. So as we just heard, Dr. Shriodkar helped the women in India not only by providing good OBG services, but particularly by his path-breaking surgery on incompetent cervix, the new instruments that he made, and his championing of the contraception and abortion rights. Remember, that was a time when contraception and abortion was really a challenge. It wasn't so easily available as it is now. He was a member of the Family Planning Association of India as a founding father of that, and had written, was a part of the Shanti Lal Shah committee. And this, we all heard now how he was known nationally and internationally, and had some very, very famous patients, starting from Sophia Loren outside India to our very own Indira Gandhi. So he was also a painter, and this is a painting of the Haji Ali that he has made himself, and this is available in one of the papers that Dr. Purandare has written about Indian contribution to obs and gynae, and he has shown this picture there. Dr. Shriodkar also received both the Padma Bhushan and Padma Vibhushan, and this is a little video where we will look at the Shriodkar procedure, all of us, which we talk about. So these are the instruments there, and this is all part of that Diamonds Are Forever series, so you can go back and see there. So what he actually taught us was, instead of using, now we have Marceline tape, we have everything, but at that time we didn't have all this material. So his exact technique involved taking a piece of the fascia lata by making an incision on the skin of the lady.
Incision is made. Dissection and mobilization of the upper end of the strip
Are you able to hear?
accomplished, and a similar blunt dissection above and below is carried out. The strip of fascia is then removed. It is approximately 10 to 15 centimeters in length, depending on the size of the cervix. The strip is placed in normal saline until needed. A posterior fornix incision is made, and mobilization of the tissues started.
That's an incision in the posterior fornix.
The anterior fornix incision, dissection, and mobilization of bladder and paracervical tissue at the level of the internal os is accomplished. A slip knot is used to lead the fascia through the paracervical area at the level of the internal os beneath the cervical fascia. The left fascial director is introduced and further blunt dissection carried out. The fascia is attached to this left director and the strip pulled out at the anterior fornix incision. A similar procedure is employed on the right side of the cervix with the right cervical director. The fascia is now encircling the cervix at the level of the internal os.
Dr. Shriodkar was a very famous and sought-after obstetrician. He was Mrs. Indira Gandhi's obstetrician and delivered Mr. Rajiv Gandhi. Because of his skills, he had baby born in India after a successful Shriodkar study, Dr. Manu Sopti. Dr. Manu Sopti is a urologist practicing in Mumbai, and we have him with us on.
He is the first person born after the surgery on his mother.
Father and my mother. My father, Dr. Kashinath Sopti, he was a surgeon. And he would often assist Dr. Shriodkar in his surgeries. And my mother, who was a gynecologist too, she went on losing pregnancy after pregnancy. And Dr. Shriodkar in sometime maybe in 1953 or early 54, told my father that I am thinking of this new idea, that women who keep on losing their pregnancies, why not, sort of close the gate. And probably this was one of the earliest cases that he did. And my mother would, she showed me a long scar, almost more than a foot long, running along the lateral side of her thigh, from which he had harvested a ribbon of fascia lata. And in the November of 1954, I was born by a cesarean section at Dr. Shriodkar's hands in Kambala Hill Hospital. It's running even today. Unfortunately, I had no personal interaction with him. But Uday tells me I was probably the first to be born like this. Now, as regards Dr. Shriodkar, when I myself joined surgery, and I used to be keen, to find out about the grades. So I used to ask my dad, that he used to assist Dr. Shriodkar, and what was special about him. So one sentence he told me, which I remember almost really ever so often. He said that Dr. Shriodkar, when he would be operating, it would seem that he is operating very slowly. That the surgery would get over in just no time. So his movements were slow, deliberate, but absolutely focused on achieving a certain outcome. And I have tried to keep that in mind when, see, all of us as surgeons are trying to better ourselves. We will continue till the day we stop practice. But this is something that I learned from my dad, and with what he tried to pick up from Dr. Shriodkar, that every movement, every surgical movement must be aimed to achieve a definite outcome. One more thing I do remember my mother telling me, that once he had put the cerclage stitch on her, he would come to our nursing home and
I think it ends there. What he was saying was he would come to their nursing home every weekend and check on her, because she was one of the first persons having undergone the Shriodkar stitch. And people often comment on prenatal interventions, that what is the effect it is going to have on the fetus. And you have this fetus who has become a surgeon himself. And I think Rohini madam told me how he had intervened in rhesus isoimmunization and done exchange transfusion in those days, and people have had successful lives after that. So this has already been quoted, but I think it really puts things into perspective, where he had a vision, and we always say that a vision without action is just a dream. And an action without vision just passes the time. But when you have vision with action, it can change the world. And really, we are proud when in all the Western textbooks, there is the Shriodkar method mentioned as a very, very successful method of tackling cervical incompetence, which despite everything, we still don't have a good option now. The only thing that has changed is the material that we use. Instead of fascia lata, we have now found biocompatible material, but the technique very much remains the same. So for an innovative doctor, thinker, and an egalitarian service provider, I stand humbled to deliver the oration in the memory of this legendary doctor. Thank you very much once again for giving me this opportunity to deliver the Dr. V. N. Shriodkar Memorial Oration 2022. Thank you. So the topic that we have chosen this year is rhesus isoimmunization yesterday, today, and tomorrow. Now, rhesus isoimmunization is something, again, which we identify only if we have a high index of suspicion, although it should become routine now. So, about 50 years back, you could have seen an obstetric story like this. There would be a young, healthy woman who delivered the first child. Everything was fine, great experience. And since always we've wanted a couple of children to have siblings for our children, the next pregnancy, the child would have severe jaundice, would not thrive well, and there would be abnormal movements if it survived. That would be very sad. You go on and have another pregnancy, which would probably end with a fetus looking very swollen, and similarly, any number of pregnancies that she tried thereafter would be unsuccessful. And this problem was quite severe in the common population, most of which we did not know. But you've heard story of the Tudors, of Catherine of Aragon, of Anne Boleyn, where there are references that probably the problems were because of red cell isoimmunization, and that even led to changing the course of history, splitting of the Church of England, and things like that when it happened in the royal families. So this was a cause of a lot of distress, and hemolytic disease of the fetus and the newborn was a major challenge for medical practitioners in the yesteryears. When we look at yesterday, the historical perspective says that hemolytic disease of the fetus and newborn affected about 10% of perinatal deaths. So 10% of perinatal mortality was because of rhesus isoimmunization, which we now know is a completely preventable cause. So we have lost so many babies in the past because of lack of understanding and a lack of awareness or a lack of, method of preventing such diseases. So if you look back there are literature in the Association of Clinical Pathologists, there are reviews in old BMJ references where people have talked about this problem. If you look at the archives, you see that these were described. But ultimately, it came down to these two people, Karl Landsteiner and Alexander Weiner, who described the rhesus blood factor. Now, every discovery goes through certain cycles. So it was described, but then there was a newspaper article in the New York Times in 1944 which said, well, something has been described, but we don't think it causes the childhood deaths, and it was dumped. It was again re-understood, and people said that, oh, we should have given more weightage to what was described by Weiner in 1940, and probably there is some evidence and there is some strength in that argument that there is an extra factor in the blood group which causes these kind of deaths. So then we got to re-understand the blood group system. The ABO system was something we all knew. So blood groups are either A, B, O, or AB depending on the various combinations. But the second factor, that is the rhesus factor, is coded by a gene on the 6th chromosome. And then you are either rhesus positive or rhesus negative, depending on the D antigen, the capital D antigen. So there are many other antigens which are also coding for the rhesus factor, but it's the capital D which is the most potentially damaging, and therefore that is what we are looking for when we talk about rhesus positive or rhesus negative. When the D antigen is present, it is D positive. When it is absent, it is D negative. So the nomenclature for these D antigen came from the Fisher race nomenclature, and that described the rhesus genes by appropriate letters, the capital letter for things being present and the small letter for the recessive variety. The D small is not available, so you are either D positive or D absent. And this rhesus name came from the rhesus macaque monkeys. Now, the initial experiments were done on rabbit blood by injecting them with the monkey serum. And this was found in the rhesus monkey antigens, so somehow the name stuck and it was called as. Now, interestingly, the rhesus positivity is almost 100% in the African race, whereas rhesus negativity is more in the Caucasian blood. So somehow that there has been a lot of, there is a lot of funny literature available where when there is a battle of racial supremacy, the African population has said that we are supreme as we are immune to this kind of a condition of rhesus isoimmunization. But that is not, not scientific or anything as such, but it's something that has been in the background of such science development. So when we have D antigen, we are rhesus positive. When we do not have the D antigen, we are rhesus negative. Irrespective of the ABO blood group, you can have a rhesus positive or rhesus negative. And the father's genotype is the key factor. So when somebody is rhesus negative, both the genes are negative. When somebody is positive, then he can be a homozygous positive or a heterozygous positive. So you could have two positive parents and the child can be negative. I am an example of that. My parents are O positive and O positive. I am O negative. Because I think both of them carry the heterozygous genes and I have inherited the negative pattern from them. So the good thing about O negative is it's a universal blood donor. So a person who's O negative does not have antigens, does not have antibodies, because the rhesus antibodies are not inherently present in our body. If a negative person is exposed to positive blood, then it can make antibodies against the positive blood, and that is the crux of the story. So when the mother is rhesus negative, what will be the blood group of the fetus will depend on the genotype of the father. So if the father is a heterozygous positive, if the father is negative, then all babies will be negative and we will not have the problem of rhesus isoimmunization. However, if the father is rhesus positive and he is a homozygous positive, then all children will be rhesus positive. We don't have to worry at all. Everybody will be positive. We have to take the same precautions every time. If the father is heterozygous, then 50% of the children may still be rhesus negative. Why this information is important? Because if the child is negative, you do not need to give anti-D. You don't need to worry about isoimmunization problems. You don't need to do Dopplers again and again. So if you could establish at the beginning of pregnancy that the child is rhesus negative, the fetus inside is rhesus negative, then half of your problems are gone. But this was yesterday and this was not possible. We'll come to today and see whether it is possible, but let's understand the problem a little bit better. So the designation of rhesus positive or negative is because of presence of the D antigen on the red blood cell membrane of an individual. And this D antigen can incite somebody who is D negative antibodies against it. Now, whenever antibodies are produced, they will attack further those cells which have the D antigen positive and cause the problems. So this was a paper in the seminars of fetal and neonatal medicine where they had studied the impact of rhesus disease on the global problem of bilirubin-induced neurological dysfunction. So where was the problem? If it had hydrops fetalis, you were not that much worried because whatever it was a one-time mortality and that did not affect life for a longer period, except that the woman would be distressed that she would not be having successfully pregnancies. But suppose the child lived, then because of this excessive destruction of blood cells, there would be unconjugated hyperbilirubinemia, and that could cross the blood-brain barrier and cause a condition called kernicterus. Kernicterus is when that unconjugated bilirubin goes and acts on the basal ganglia and causes unusual movements or neurological instability in the child. And having a child with long-term neurological morbidity is something which is a big burden for the individual family as well as the whole society. So rhesus prophylaxis was something that was a burning requirement in the first half of the 20th century. People knew the problem, they understood the problem. In the 40s, all this was discovered. They understood what it was, but they didn't know what to do, how to get over this problem. Today, we are in a better situation because we understand the problem very correctly. We know that if there is a rhesus negative woman, she neither has antigen nor has antibody. If she conceives a fetus who is rhesus positive, then the fetal cells can migrate into maternal circulation sometime in the pregnancy, more commonly in the 3rd trimester, very commonly during delivery, and at that time they can incite a reaction. Because the timeline is such that most of the problems happen during delivery and 3rd trimester, the first pregnancy usually goes off uneventfully. But when the interaction of the mother and the fetal cells occur, if there is nothing to block the production of maternal antibodies, she will produce a lot of antibodies. So like our regular human immunological reaction, our first antibodies might be IgM. They don't cause a problem, but the later antibodies that are produced are the IgG antibodies, and IgG antibodies are very small and they can cross into the placental barrier. So when she has a next pregnancy and she has IgG antibodies in her body, those antibodies will go into the fetus, and if the fetus has rhesus positive blood group, then the antibodies will start attacking the red blood cells of that fetus, causing hemolytic anemia. And hemolytic anemia causes hepatosplenomegaly. Hemolytic anemia is anemia in itself, and because of the whole problem can lead to the condition called hydrops fetalis. And that is where our challenge is to prevent this formation of the antibody. That could be the first way of tackling this problem. Now, where is the problem exactly? If you look at the entire population, when you look at the global distribution of rhesus negativity, the maximum is in North America. Europe also has about 10% of rhesus negativity. India is about 5%, whole of Asia would be about 1 to 2%, and in Africa it's actually a lot lesser. So when the mother is rhesus negative and the father is rhesus positive, we need to know if the fetus is rhesus positive, and if the fetus is rhesus positive, how can we stop it? So the first pregnancy in a rhesus negative woman is usually uneventful. Any pregnancy in a non-isoimmunized mother who is rhesus negative is uneventful, even if she has rhesus. So the problem is only when the mother has antibodies against a positive fetus and the fetus itself is positive. Only then there will be a problem. So if the mother has antibodies and the fetus is rhesus negative, there won't be a problem. But if the mother has antibodies and the fetus is rhesus positive, that is where the entire problem lies. Now, does this happen to all rhesus negative women? Because all of you have seen rhesus negative women. But yesterday I was talking with some of our colleagues and they don't see the problem of isoimmunization that much. So why is that? That is because about 30% of women have an inherent immune non-responsivity. They don't make these antibodies. That's just by chance. It's nature's defense mechanism, but that's just by chance. And the other thing was, till now, we were not able to detect things also very well. The availability of the antibody testing was not that much. But in the last 2 or 3 decades, I think we have gone far ahead. We are able to identify the problem. We are able to see the antibodies. So now we must get alerted, because very many times we may not even be realizing that we are dealing with rhesus isoimmunization. But now that's not the case, and these kind of outcomes are no longer acceptable in today's obstetrics and gynecology. So it is important to screen women for rhesus negativity and find out those who are at risk of hemolytic disease of fetus and the newborn. So what do we screen for? At the time of the booking of pregnancy, every woman should have a blood group and a rhesus status done. Do we all agree on this or not? We must. Now, if somebody is rhesus negative and this is her first pregnancy, should we do an ICT, an indirect Coombs test in her also, or should we just do it in women who've had previous pregnancies? We should do it for all, agreed or not agreed? So any rhesus negative woman who comes to an obs and gynae clinic should have an indirect Coombs test done in that pregnancy, even if she is a primigravida. Let me give you an example. Recently, we had a referral from the hematology department. A woman is a primary gravida, but she's ICT positive. Now, she's a known case of immune thrombocytic purpura, and she's been receiving blood transfusions over and over in her childhood. So, at some point, there must have been some mismatch, and now she's ICT positive. So, even if she's a primary gravida, she is at risk of hemolytic disease of the newborn. I'll tell you the second part of the story after some time, because there is an interesting catch in that. But out here, what we have understood is, today, if anyone comes to you who's rhesus negative, we go ahead and do the ICT. If the ICT is negative, that means she does not carry any antibodies against D antigen, and that is very reassuring. Because even if it's a 5th pregnancy, from the rhesus point of view, it's as good as the first pregnancy, because she is not iso-immunized. If the ICT is positive, then we still don't know what is the blood group of the baby. If we could know the blood group of the baby, our problems would be solved. But how will we know the blood group of the baby? Is there a method of checking the blood group of the baby? We can do amniocentesis, isn't it? We can do amniocentesis, and from that we can check the blood group of the baby. We can do fetal blood sampling and check. Are you comfortable with this, what I'm saying? Are you comfortable with the idea of doing an amniocentesis or a fetal blood sampling to check the baby's blood group? Why? Because it's an invasive procedure. And if she was not iso-immunized till now, you are actually doing a sensitizing thing. You may cause iso-immunization just in the excitement of finding out the blood group. So that's not something which is recommended. So we are still in a doubt. Now, when in doubt, you assume the worst and work accordingly. So when you're in doubt whether this baby is positive or negative, and my problem is only if the baby is positive, I will assume that the baby is positive. And that is what we have been doing all through in our management of rhesus negative pregnancies, where we have been assuming that the baby is positive. If the baby is positive and the mother has antibodies, then there can be problems. What problems? Hemolytic anemia. What is the treatment of anemia? What is the treatment of hemolytic anemia? It's not iron, it's blood, replacement of blood. So if that happens, we have to replace blood. Many years back, that was not possible, but now that is possible, and we can give extra blood to the baby in utero and allow the baby to overcome the anemia. All we need to know is, does the baby need blood transfusion? And if it does, how much? So what we do is, we do the middle cerebral artery peak systolic velocity. Yesterday, we were doing amniocentesis and looking at the optical density of the amniotic fluid to find out how much bilirubin is there in the system. And we were assuming that the bilirubin is coming from hemolytic anemia, and therefore it used to give us an indication of how much blood the baby might need. But today we have a better method, which is a non-invasive method, and that is checking the peak systolic velocity of the middle cerebral artery in the fetal brain. The way fetal circulation works, the most oxygenated blood is given to the fetal brain. So whenever there is anemia, because the blood is so thin and the blood velocity is so high that the middle cerebral peak systolic velocity will exceed a certain limit. So whenever middle cerebral artery peak systolic velocity is more than 1.5 times the multiples of median, then we assume that the baby has significant anemia which needs transfusion. If we do not give transfusion, we will be progressing towards fetal hydrops. So that is why anybody who is ICT positive is put on a protocol of 2-weekly middle cerebral artery peak systolic velocity Doppler after 16 weeks of pregnancy, because all these transfusions and all can only be done around 18 to 20 weeks and thereafter. Before 18 to 20 weeks is yet another challenge. So what do we do in cases of management of rhesus negative pregnancies where we want to avoid this kind of sensitization? Why did the sensitization occur in the first place? Because something was not managed well when there was a first pregnancy with a rhesus positive baby. And what could be done? At the delivery of anterior shoulder, hold on, don't give the oxytocin so soon, because the placenta is still inside. And you give an oxytocin, you are increasing the feto-maternal bleeding. Manual removal of placenta, try and avoid, because again you can increase the feto-maternal bleeding. If blood transfusion is indicated, use rhesus negative blood only. Early clamping of the umbilical cord and leave a length of the cord because exchange transfusion may be needed in those babies. And send samples for ABO or rhesus typing, direct Coombs test, hemoglobin, bilirubin, and a peripheral smear. If fetus is rhesus negative, after all this, when you have done and the fetus is rhesus negative, relax. No problem, no damage done. If the fetus is rhesus positive, then you have to give an anti-D. Now, anti-D is also antibody. ICT is positive because antibodies are present. When antibodies are present, we are worried. And we are giving anti-D after the delivery. Why? Where is the trick here? We are worried about antibodies being present in the system. We don't want antibodies to develop in the system. But after every delivery, I am repeatedly telling you, please give anti-D. Absolutely. See, the wisest people are the ones who we have to hear from, because these are blocking antibodies. See, how does the body respond? Suppose I am encountering an unpleasant element from outside. So what do? I get angry, I get damaged, something happens to me. Now, to prevent that, what do we do? If there is a mob coming, what is the latest recommendation? Keep bouncers, isn't it? So your bouncers will go and handle the mob. The mob will not get a chance to meet you. So similarly, in the system, these antibodies which we provide, they go and bind to what is happening in feto-maternal hemorrhage. The red blood cells from the fetal circulation are going into the maternal circulation. And these cells have the antigens. Antigen can generate antibody if it meets the immune competent cells. So before it meets the immune competent cells, you fill the system with antibody. This is externally given antibody. So this will go and bind with all the antigens that have come into the maternal circulation, and in some time it will clear off the entire antigen thing. So the antigen will not get a chance to incite an immune response in the mother. So this is what we call as passive immunization. The body's immune cell does not produce that antibody. Instead, the body's immune cell is not allowed to produce the antibody. There is no memory created. There is nothing that is told to you. So you are working inside your clinic alone, not knowing what's happening outside. Your bouncers have gone and sorted out the mob, and the mob has gone off. If the mob had come inside, there would have been a reaction, there would have been something, and then you would have carried on the memory forever, and there would have been damage done. But here, your the anti-D which you provide, that gives those antibodies freely in the circulation, which bind with the antigens and do not allow the mother to get isoimmunized. So that is why it's called prevention of isoimmunization. So whenever you do any specific event in a rhesus negative pregnancy, these are the ones which are listed here: chorionic villus sampling, amniocentesis, chordocentesis, threatened miscarriage, ectopic pregnancy, evacuation of a molar pregnancy, usually a partial mole, because complete mole doesn't have the blood group antigens, therapeutic termination of pregnancy, antepartum hemorrhage, abdominal trauma, intrauterine fetal death, external cephalic version, or delivery itself. All these things involve some degree of breach in the choriodecidual region. And once that breach is there, some of the cells from the fetal origin can migrate into the maternal circulation. So that is why called the sensitizing events. Similarly, in particular pregnancies like where you have a cesarean delivery, where you have multifetal gestation, already massive antepartum hemorrhage or manual removal of placenta, you expect that there would be a lot of feto-maternal hemorrhage. So there you also think that not only it is sensitizing, but the amount of blood that must have gone through may be more. And why is that important? Because it is a sensitizing dose. So you know that this much of dose can incite this much of response. So if the dose is much more, the response also may be much more. So when you are providing blocking antibodies, if the dose of antigen is much higher, your blocking antibodies may not be sufficient. So it is important for you to know how much of blood must have migrated into the maternal circulation. Now, the amount of blood that is required to incite a response may be as low as 0.1 ml or as large as 30 ml, or it may not respond at all. I told you 30% of women are non-responders. So for them, it doesn't matter. Whatever dose you give, maybe they won't respond, but you don't know. So because of that ignorance, we have to treat each and every rhesus negative woman as somebody who can potentially get isoimmunized. So what do? We give anti-D within 72 hours of the sensitizing event. The original work on this was done in 1960s, and it was, anti-D immunoglobulin was extracted by cold alcohol fractionation from the plasma donated by individuals who already had the antibodies. So all those who were isoimmunized, they already had the antibodies, and their antibodies were taken, fractionated, and therapeutic doses of antibodies were created to act as blocking antibodies for other women. This work was done in 1960s by a scientist called Jörg Schneider from the Freiburg University of Germany, and he was considered as one of the first investigators, and the exact date of that achievement is August 9, 1963. And then, of course, he reported that this worked on women who were isoimmunized, but not until 1965 was this actually published and accepted as a treatment, and then injected into the rhesus-negative mothers. The antibody bind and destroy the rhesus-negative blood cells that have passed from the fetus to the mother during birth. So summarily speaking, the prevention of the rhesus D factor alloimmunization, which started in the higher income countries, remains one of the most important accomplishments of the last century. And all those who had gone to the FIGO meeting in Brazil, in Rio, would remember how they celebrated 50 years of the anti-D in a session, where, because it was almost 50 years since when it was being used in clinical practice, and they went through that entire journey, because if you remember, we started by saying 10% of perinatal deaths were because of rhesus isoimmunization. So when you can bring down 10% of your perinatal mortality by a single intervention, it is by far one of the most path-breaking interventions of the last century. We are lucky to have anti-D with us all the time, but we are still unlucky because we still see rhesus isoimmunization. And what is the reason? We need to think again and again, because many of our women say that they have received anti-D in the past pregnancies. Still, they come back with isoimmunization as well as fetal effects. So somewhere we have to understand what is the reason of the failure of rhesus isoimmunization. And some of the common things in our country is the breaking of the cold chain, because this needs to be maintained at a temperature which probably we don't do when we transport it from one place to another. The other one is administration problems. How many of you know the exact site where the rhesus anti-D should be given? It is given in the deltoid. So that is something we don't tell our staff very often. We just say it's an intramuscular injection, and all intramuscular injections by default are given in the gluteal region, and that's given in the gluteal region. The absorption is not good if it is given in the gluteal region. So all the anti-D injections have to be given in the deltoid region, and an accurate amount should be given. This is the method of how anti-D is produced. There are two types of anti-Ds, polyclonal and monoclonal. And they are made in a different manner, and this is one of the recombinant technologies to make anti-D. The first one that I told you was human extract. You know, people who have the antibodies, you take it from them and extract it by cold fractionation. There is another method where you take the gene which produces antibody and then mix it with the hybridoma cells and make it. This is called the recombinant. In fact, the Indian anti-D which we have is the recombinant variety. The international variety which we have is polyclonal, but that is the human extract. When it is a human extract, there is a potential for allergy. It is not very well documented, but some cases have been seen. I mean, we've also had a case of allergy to anti-D, so we have to be a little careful, because at the end of it, it is a protein. So the reduction in hemolytic disease of fetal and newborn by the anti-D has been dramatic. A single dose of anti-D within 72 hours of delivery reduces the risk of rhesus alloimmunization by 80 to 90%. And some of the fetal maternal hemorrhage occurs even in the third trimester. Therefore, if we can give one dose in the third trimester, the risk of isoimmunization would come down to as low as 0.2%. So failure of administering this in the third trimester is one of the reasons. Insufficient dosage is one of the reasons. Unrecognized fetal-maternal hemorrhage at some point in pregnancy. So what happens? You've done an ICT at the beginning of pregnancy. Maybe you've done an ICT in the middle of pregnancy. But then you didn't do it in the last 2 weeks of pregnancy. And that is when the fetal-maternal hemorrhage occurred. Then the baby delivered, you gave anti-D after the pregnancy, but the woman still remained isoimmunized because the sensitizing event happened sometime in the third trimester, which was not detected. So the latest guidelines say that giving a routine antenatal anti-D prophylaxis at the 28 weeks, 34 weeks, and then after delivery is one of the effective methods of minimizing RH isoimmunization. It's not 100% effective, so you are never going to say that I can completely prevent it, but that's the best that we can do that way. When we say that the amount of blood may be more and our dose may be less, how do we know how much is the exact dose to be given? In an ideal setting, we should do what is called the Kleihauer-Betke test. It's not a very difficult test. Actually, I don't know why labs are hesitant about providing it as a clinical solution. I think it is only because it requires a little bit of human effort. Because all your hematologist has to do is make a smear and put acid on it. The maternal cells become ghost cells, and the fetal cells are seen because they are acid resistant. So it's called an acid elution test. So if in 50 high-power cells, you see 80 fetal RBCs, it is estimated that the fetal-maternal hemorrhage is 4 ml. So it's very simple calculation. We have managed to tell some of our pathology clinic colleagues to do it for us, and they do it and they give us a result. But even they smile when they ask us, why don't you give it as a clinical support service? But this is something which can be done. It's not a very high-tech test as such. It has a very fancy name, but it is easily doable. And if it is done, then you can quantify how much anti-D you have to give. Because the other method of quantifying fetal-maternal hemorrhage is called flow cytometry. Now, all the centers which have transplants and all kinds of fancy things going on, they will have a flow cytometer. So that also can be done, but the cost of flow cytometry is very high. But that will also help you in quantifying how much bleeding has occurred. And why is that important? Because you should know that 10 micrograms of anti-D neutralizes 1 ml of fetal blood. So with that calculation, 300 micrograms of anti-D, that is the dose that is available for us, 300 micrograms is equal to 1500 international units. And that can neutralize 30 ml of fetal blood. And 30 ml of fetal blood would approximately have 15 ml of RBCs, assuming a hematocrit of 50%. So 300 micrograms is neutralizing 30 ml. And 30 ml is a very, very large quantity, if you think of it. 30 ml, if you imagine how much it is, it's a very large quantity. So practically speaking, the 300 micrograms that we are giving should be able to mitigate most of the problems that we have, and therefore that should be sufficient. But still, it would be an ideal situation if we could do a Kleihauer-Betke in all cesareans, manual removals, and any case multiple pregnancies, wherever we think that there could be more things. So this calculation, please remember, 100 micrograms is 500 international units. It can neutralize 10 ml. So 10 micrograms, 1 ml. It's just mathematical the same way. Now, what are the best screening methods? Of course, blood group, and the next is indirect Coombs test. So when a woman comes to us at booking, she's rhesus negative, we do the indirect Coombs test. When do we repeat it? In a routine pregnancy at around 28 weeks, because that is when we plan to give the first shot of anti-D to prevent isoimmunization by any silent fetal-maternal hemorrhage. After giving an anti-D at 28 weeks, when do we do ICT? We do not do ICT again. Because if you do ICT after giving anti-D, it will come positive. And then you will be worried. That happens very many times. But this worry is because of the antibody that we have given. How can we differentiate whether this is inherent antibody or this? We can do a panel on that ICT and we can do titers. Any anti-D which you have given and which has caused the ICT to be positive will not have serially growing titers. The titers, if at all, will be becoming less with time. If it is inherent antibody, it may probably increase. So after giving an anti-D, it's better not to do an ICT at least within the next 6 weeks, because that is the half-life of the anti-D that we give. Now, indirect Coombs test, it is a qualitative test. What does it do? It looks for the antibody that is present, and once it looks for the antibody that is present, quantitatively it is represented in titers. So the result that you get is ICT positive or negative, and when you ask for the titers, they give you titers in dilutions. So 1 in 4, 1 in 16, 1 in 32, 1 in 64. Now which is more? 1 in 4 is more or 1 in 32 is more? 1 in 4 is more or 1 in 32 is more? It is the dilution, serial dilution. So 1 in 32 means you have diluted the sample 32 times and it is still positive. 1 in 4 means you have diluted the sample 4 times, it is positive, but when you dilute it 8 times, it is negative. Then you report it as 1 in 4. If you are diluting your sample 512 times and it is still positive, that means the antibody is much higher. So when you dilute it, you keep diluting it in doubles, and when you reach a point that it is negative, you report the previous one as the titer. So 1 in 32 means it is positive when it is 32 times diluted, but negative when it is 64 times diluted. So when you have it positive at 1 in 64, that is much more than 1 in 2 or 1 in 4. So the higher the denominator, the higher the presence of the antibody. So when the titer says 1 in 32, it's considered as critical sometimes. If it is 1 in 4 or 1 in 2, you don't worry that much. So that is how the titers work. Now a little more confusion. Everybody who is Rh positive or Rh negative is not as simple as that. There are some people who have a weak positive or a weak negative. Have you heard of weak negative? So people who are weak negative or partial negative, the weak negative and partial negative are different in terms of their pathology, but in terms of the clinical application, they are the same. So I put them both on the same slide. If they are weak negative, they have very less antigens on the membrane. If they are partial, then some of the antigens don't work. So whatever it is, when they are weak, you consider them as rhesus negative if you give them blood. You don't give them rhesus positive blood. But when you take their blood, you consider them as rhesus positive, because even the slightest of antigens can incite a reaction. So while giving blood, they will be considered as positive. While taking, they will be considered as negative. So this blood group is important from the husband's point of view. So if the husband is a weak positive person, then also he has the capacity of having a fetus who can incite a reaction, because he will be considered as a positive person when he is a donor. But when he will receive blood, he will receive negative blood. So that is where there is a confusion. So a lot of us have this thing, if the husband is negative, we won't give anti-D. So you should be sure that he is not a weak positive kind of person where you may still need to give anti-D. So these are the few things where I can confuse you with rhesus. There's another kind of blood group which is called rhesus null. They don't have any rhesus antigen or antibody, and this is known as a golden blood group. But still, they can have problems which can lead to hemolytic anemia. That's a very, very rare thing. Only 43 individuals have been reported. So I just put it to sound a little clever here. So then comes the other thing. When we do ICT, it's a qualitative test. Now, because we work very closely with fetal anemia, we have realized that apart from D, all the other antigens and antibodies also have a role in this ICT story. So we do what is called a 11-cell panel, where the hematologist looks at a lot of atypical antibodies also, and then gives us a report like this. So this is an 11-cell panel where they look at A, D, C, E, and sometimes it's G also. So they give, because when we have to transfuse blood into these fetuses, we need a cross-matching of all these things. And therefore, although the simple story is about anti-D, when it comes to the transfusion part, we need this clarification. Now let me remind you of my first story, which I told you that the woman was rhesus negative. She was a primigravida, but she was ICT positive. And they were very worried because she's had a very tumultuous childhood with multiple blood transfusions. Now she is pregnant, and husband is rhesus positive, and now she's ICT positive. So the hematologist was very worried. She was sent to us at 6 weeks of pregnancy, and we sent for an 11-cell panel. When we sent for an 11-cell panel, it was very surprising that she was not D positive. She was E positive, anti-E positive. Her ICT was positive because she was not producing anti-D antibodies. She was producing anti-E antibodies. Because we also thought that every time she must have been cross-matched for at least positive-negative cross-match is done in every blood bank. So she was cross-matched for rhesus positive every time, and therefore she always received rhesus negative blood. But she was not cross-matched for the E, C, and other antibodies. So at some point, she developed isoimmunization to anti-E. Then what we did is we did the husband's typing, because he is D positive for sure. He is a rhesus positive person. But when we did his E typing, he has come out to be E negative. So now we have this lady who is ICT positive. She is rhesus negative, but D negative and E positive. So she is still a candidate for anti-D, because the fetus will be rhesus positive and she needs anti-D. Even if she's ICT positive, we have to give her anti-D because she's not D positive. And since the husband is also E negative, the fetus will also be E negative, because she is E negative and her husband is E negative. So that anti-E antibody is unlikely to affect her fetus. I need all your blessings for that baby. She's still around 20 weeks right now. She's carrying on with the same plan that we are looking at her every 2 weeks, doing the MCA Dopplers, because she's also worried, we are also worried. But our theory is that the fetus won't be affected because she's not D positive and the baby is E negative. So that is why there is an advantage in doing these 11-cell panels, and we have made it a routine for all ICTs to do this, and we are finding a lot of surprising things also, because some of these conditions, like, when the fetus may have a different kind of antibody, whenever you do blood transfusion, it has to be matched with all of them, otherwise it won't work. So what else could we do? We always want to do better. So what else could we do? We could look at the father's genotype. If the father is a homozygous plus, then all the children will be positive. Then we have to instigate all these defense mechanisms in all children. But if the father is heterozygous, there is a possibility of the baby being rhesus negative. If you have a very high titer of maternal antibodies, and you know that the baby is rhesus negative, you can breathe a sigh of relief. How can you know that? There is a possibility now that you can know the fetal genotype by cell-free fetal DNA. The NIPT test that we use is the same test which can be used to tell us the fetal rhesus status. It's a very expensive test at the moment, available at very, very few centers in India, and they insist that the blood has to be given in their center. Like the collection of NIPT, we send the samples anywhere. They say, no, send the woman, let her give the blood in our lab, then only we'll be able to say. Like in Gangaram Hospital, New Delhi, it's possible. But they want the woman to travel to Delhi to have that information. So it's not being very practical, but that's something in the pipeline. Analysis of amniotic fluid for the spectrophotometry is no longer done, but MCA Doppler is the current practice. So once a woman knows that she's isoimmunized, it is better to follow the MCA Dopplers. And this was the chart. Earlier you were used to the Liley's chart. Liley's chart was based on the optical density of the amniotic fluid. This is based on the middle cerebral artery peak systolic velocity. And the theory is very simple, that whenever there is fetal anemia, the blood vessels will be very fast, the blood flow will be very fast, hyperdynamic circulation will be represented by high peak systolic velocity in the middle cerebral artery Doppler. It's a simple, non-invasive method of detecting fetal anemia, and it is so strongly correlating with fetal anemia that as of today we do not do pre-transfusion sampling. We get the fetal hemoglobin only at the time of the transfusion. In fact, this is so accurate that now there are papers which can tell you that if your MCA is at that level, what is the expected hemoglobin range, and I'll show you how we work on it. So this is a fetus. You can see the MCA peak systolic velocity is above 1.5 moms, and we have decided that she needs a transfusion. So once you decide for a transfusion, you prepare the blood. And the blood for transfusion is always O negative. Whatever the blood group of the mother, doesn't matter. The blood which has to be transfused has to be O negative. O negative, gamma irradiated, leukodepleted, and it's usually a pack collected within the last 1 week. So they need fresh blood for that. And it has a single pack with a very high hematocrit, low volume. So about 80 to 90% hematocrit we have in that pack which comes for the fetal blood transfusion. So first and foremost, you have to assess the cord insertion on the placenta. So suppose the anterior is what you can see towards your screen. So if you see the cord is anterior, then you know that your access is easy. If the cord is posterior, then you know that you cannot access the cord insertion. You have to think of other points to transfuse blood. And then you try and put your needle into the umbilical cord, and if you can see, that is the blood flowing in the umbilical cord. Once you have accessed the cord insertion and started your transfusion there, can you see that waves of like liquid passing through that, and that is an indication that blood is flowing freely there. So you see this, there is blood flow that you can see there, your needle, that is the needle tip in there at the cord insertion, and then blood goes in. When you keep doing the transfusion, the first time when you put the needle in, we aspirate about 2 ml of blood and send it to the lab to check the hemoglobin and the hematocrit. That report comes in about 5-6 minutes. In the meantime, we start transfusion. So in fact, when you look at the color of the blood only, you know, because it's around orangish that time. And then this is the centrifuge which separates the blood. This is the preparation of the blood actually. These are the leukodepletion filters, and they take away all the white cells so that the reaction is less, the graft versus host disease is minimized. And then you check for gamma irradiation. So on the normal packs, they will be written not irradiated, but the packs which are given for fetal transfusion, they would have written there that this has been irradiated. Then you put the blood pack there, and you start the transfusion. So one operator puts the needle into the desired site, the other operator does the transfusion. And here we get the report. So this was a hemoglobin of 7.9, and then you look at the pre-transfusion MCA and the post-transfusion MCA. So because you're doing it under ultrasound guidance, you have the capacity of doing both at the same time. So you look at the middle cerebral artery before you start, and then you look at it before you finish. Sometimes when the placenta is posterior, I don't know why the video is not working, you'll have to go through the umbilical vein. So that is, this is the abdomen, cross-section of the abdomen of the baby, and that is the needle going into the umbilical vein. So when we can't get the placenta, we transfuse through the umbilical vein, and in the similar fashion, look at the pre-transfusion MCA and the post-transfusion MCA. So this is usually the type of history that we get, where a woman has had multiple miscarriages and multiple losses of babies, and her titers are 1 in 128. So that is pretty high titers. And whenever she requires a transfusion, like I said, we don't know the exact hemoglobin before doing the transfusion. So what we do is we work up for all possible hemoglobins. So you look at the different charts, and this is another practical point for people who are ever going to try transfusion. The amount of blood required is different if you look at the FMF protocol Barcelona protocol or the perinatology.com protocol. So what we have done is we made a comparative chart of all three of them, and we know that if the hemoglobin that you are going to get is about 4, then it will be about 51 ml. If the hemoglobin you get is around 6, it will be about 42 ml. So there are a little bit of variables that you are not sure before starting the transfusion. You don't know what the hemoglobin is inside. You don't know how much blood has to be given. So you make a preparation like this. So what we do is, one of our assistants, we need a full team to do this. So one of the assistants has this chart ready. So as soon as you take the needle in and they take the blood out, somebody finds out the hemoglobin, and then they tell us that this is the hemoglobin and this is the amount that has to be given. So if you see, the FMF requirement for a 2-gram hemoglobin at 23 weeks is 46 ml, Barcelona says 60 ml, and perinatology says 31 ml. That is because all three use different formula for calculation, but a little bit of judgment is required at that point as how much will be ideal. So these are some of our cases, and this is just to show how we do the calculation. So this was a 31-weeker, 1.6 kg baby, and the pre-transfusion hemoglobin was 3.8. So for 3.8, we assumed it as 4 ml, and we gave about 120 ml of, 125 ml of blood. So when you do that, by the time you finish your transfusion, you are able to see the MCA Doppler having significantly reduced, and that tells you that things are good and you can like stop the transfusion. Now, once you have done the transfusion, how long do you wait? So it is assumed that there is a constant destruction of those blood cells by because the antibodies are still there in the maternal circulation. So at some rate, they will be destroyed. So about 1 milligram per day, there will be a reduction in the hemoglobin. And you will assume that after 2 weeks, maybe you will need a follow-up transfusion. So we keep on doing repeat MCA Dopplers. The maximum transfusions that we have done in a fetus is 4. After 4 transfusions, even you are very scared, and if she is anyway close to 34, 35 weeks, it may be a good idea to deliver and give the transfusion excessively. So it's a controversial topic as to when you should deliver a fetus after transfusion, but the standard treatment is to prolong pregnancy until the fetus reaches a gestational age necessary for survival. And if everything is okay, you can go on till 37, 38 weeks and even induce labor. But if there is a need for a second transfusion at 34, 35 weeks, you have to take a call, whether you should transfuse or you should deliver and then see. Now, prevention is always better. So the best management of rhesus isoimmunization would be to prevent rhesus isoimmunization. And for that, awareness of blood group. And remember, for all these procedures, ectopic pregnancy, termination of pregnancy, molar pregnancy, bleeding with pain less than 12 weeks, a minimum of 50 micrograms has to be given. 12 to 20 weeks, 50 micrograms, no additional testing needed. More than 20 weeks, at least 100 micrograms, but if possible, you do the Klehor-Betke or something to see how much of the feto-maternal hemorrhage that has occurred. After delivery of the baby, a minimum of 100 micrograms within 72 hours. 100 is the recommendation. We give 300, that's good, but recommendation is 100. Whenever a higher dose is, higher feto-maternal hemorrhage is suspected, a higher dose like 300 micrograms can be given. In some cases, when you feel that you have to give more anti-D, you can consider giving that anti-D intramuscularly or even intravenously if you have a higher requirement. For that, specific guidelines are there, and it is always good to talk to your transfusion person and give those things in that way. Don't try giving it yourself, because like I said, it's a protein and sometimes it can react. But up to 8 vials of anti-D can be given if you want to prevent some kind of reaction after a massive hemorrhage. So when we talk about yesterday, today, and tomorrow, let's get back to practical points. Document your anti-D. Paste the counterfoil on patient's notes. Whatever anti-D you have given, please paste it on the patient's notes so that she knows exactly. Like sir was saying, she had a patient who said, बहुत महंगा injection लिया था. But अगर उसके पास injection का counterfoil होता, that would be a very good thing, which would definitely prove that this was the injection that they had taken. An anti-D should be given intramuscularly in the deltoid, and storage and validity dates should always be checked before doing that. Now, what is the future in rhesus negative management? The future in rhesus negative management comes from removing these antibodies. antibodies have already been formed. Can you remove the antibodies? So there is a process now which is known as plasmapheresis. You can do this process even preconceptionally, where you completely clean out the antibody from the system. Hugely expensive process, done in experimental conditions, but there are reports that it can be successful. So this was one report where they have had an alloimmunized pregnancy. In pregnancy, they have done plasmapheresis, only plasmapheresis, because there are reports of sometimes using multiple modalities. But this was a patient who was a 33-year-old G4L2D1 who had a history of alloimmunization, and from 17 weeks, they did 20 times plasmapheresis in that pregnancy. From 17 weeks, 20 times they did plasmapheresis and had a healthy baby, because they were washing off the antibodies as soon as they were produced. That's maybe one case which they have produced. I agree it's not very practical, but that is something to look forward to, because the American Society of Apheresis has recommended that this can be done, because till 20 weeks, till the 20th week of pregnancy, we can't even do these kind of transfusions. The transfusion is it's a physical process. There is a size of a needle, there is a size of that blood. So we can't intervene in very, very small fetuses. So at that time, something like plasmapheresis might help, because you can wash off the antibodies and buy time for the transfusion. But catheter-related infections, hemodynamic instability, and a severe resource utilization. These are the problems with plasmapheresis. Now, what if somebody could tell us that the fetus itself is rhesus negative and you need not worry about anything? So that is the new thing that we should think about, and that is the maternal plasma testing for the rhesus D genotype. I tried looking for this in India, we don't have it, but this is a sample request form from Germany, where you just give the sample request form like you give for your NIPT for Down syndrome, and there is a place there where they say whether it is for Down syndrome or it is for rhesus typing. So here you see there, it's for rhesus D typing, but the cost that they have written is 160 euros. So that's quite an expensive test as such. Then there is a role of IV immunoglobulin. IV immunoglobulin is a different kind of anti-D. Mind you, it's not Bar Globe. It's IV immunoglobulin. It's a different thing that is used in cases of transplants and all to prevent graft versus host disease. It's again another intervening antibody. The role of IVIG in rhesus isoimmunized pregnancies is again to buy time till the transfusion. So if somebody has very high titers and because of that she's having a hydrops at 12-14 weeks, then IVIG can help in prolonging the pregnancy. This was an Indian study done in the All India Institute of Medical Sciences, New Delhi. I think 2013 or something, it was published in the Fetal Diagnosis and Therapy. Very interesting that they did the IVIG into the fetus directly. Because the whole concept is that the antibodies will help preventing the problem. So instead of giving it to the mother and waiting for it to cross the placenta, they gave the IVIG directly to the fetus so that with a less amount of immunoglobulin, more effect could be obtained. So that is also one option. That's an Indian study by Dr. Deepika, and it was quite a successful one. So sample request form for fetal rhesus typing and this information that you can give the patients. Again, how does it work? If there are twins, how will you predict? So it works exactly the same way as NIPT does. So if it says that none of the babies are likely to be positive, then both are negative. If it says even one of them is likely to be positive, then you have the same protocol as you have for any pregnant woman. Because in twin pregnancy also, you have the same liabilities. So mind you, if the baby is negative, giving anti-D is not a harm to the baby. But if the baby is positive, not giving anti-D is a problem. So giving it is always better. So these are the patient information leaflets for the rhesus testing from mother's blood. And currently there is still a 0.1% chance that the result will be false positive or negative. So it's not 100%, and therefore the future of affected fetuses, if you have a pregnancy, if you have a lady who's battling with rhesus isoimmunization and you're not finding any way of getting through, she's having very early hydrops and even transfusions are a little late solution, then one could think of doing IVF with pre-implantation genetic diagnosis, where if the father is heterozygous, then you pick up only those zygotes which are likely to be rhesus negative. That is a futuristic possibility in these kind of pregnancies. The other option is to use a surrogate. This is one of the medical indications of surrogate pregnancy, because you can use a gestational carrier, because the whole problem is only that the mother has antibodies. So if you can transplant that zygote into a gestational carrier who is rhesus positive herself, then there is no problem. So this is one of the medical indications of surrogacy. And whenever the legislation allows or ethically it is acceptable, using a gamete donor so that you can have a rhesus negative fetus is also an option. IUI with a donor who is rhesus negative. But these are again legal, ethical, moral battles which have to be fought at different grounds, but that is a possibility. So to summarize, when we cannot battle it, we have to prevent whatever is preventable. So check blood group and rhesus typing at every antenatal visit. If it is rhesus negative, ICT must be done as soon as possible. Any sensitizing events in a rhesus negative pregnancy must alert you to fetal-maternal hemorrhage, and adequate anti-D prophylaxis can be given to prevent this whole story of isoimmunization. If it is still isoimmunized, follow up with MCA Dopplers and send to centers where intrauterine transfusion is possible. And intrauterine transfusion is very much possible. It is not such a high-tech thing that you cannot have it. I don't know whether you're doing it in Solapur or not, but I'm sure in a few years there will be people who will be offering this, because it's not difficult. I know places in Maharashtra where people have started doing intrauterine transfusion even in Tier 2 and Tier 3 cities. So that's something to look forward to. So when we talk of yesterday, today, and tomorrow, yesterday, today was tomorrow, and tomorrow, today will be yesterday. So learn from yesterday, live for today, and hope for tomorrow. Make pregnancy safer with rhesus disease. As Mary Angelo said, do your best until you know better. When you know better, then you do better. Because that is our constant mission. We have taken this promise of providing medical care, and our first principle in medicine remains, first do no harm. Thank you very much again for giving me this honor of providing. Thank you.
Thank you, Madam, on the behalf of Solapur Obstetric and Gynec Society for enlightening us on the topic of RH isoimmunization. Thank you, Madam. Thank you so much.
Request Dr. Aboli Velankar Madam and Archana Shah Ma'am to honor and felicitate Dr. Chinmay Ratha Madam with the silver plaque and citation.
The President, office bearers, and members of Executive Committee of Solapur Obstetrics and Gynecological Society are pleased to present this award of late Dr. V.N. Shriodkar Oration 2022 to Dr. Chinmayi Ratha. Dr. Chinmayi Ratha, you are presently working as Director and Lead Consultant, Fetal Medicine at Resolution Fetal Medicine Center, Hyderabad, and you have been working tirelessly in the field of obstetrics, gynecology, and fetal medicine since the last decade to disseminate practical approaches to planning and management of challenging cases. You have been working in close collaboration with doctors across the country to develop a shared care approach for hard-to-manage fetal cases. You have also headed the fetal medicine unit at Rainbow Hospitals for 5 years. You have been an awardee of the membership of Royal College of Obstetricians and Gynecologists, London, UK. Right from the commencement of your journey as a fetal medicine trainee to the expert you are now, your work has always been exemplary in giving insights into the potential of prenatal diagnosis and treatment of fetal conditions that could achieve better health goals for the sustainable development of the country. You have been clinically attached to many esteemed institutions all over the globe, and your dedication in imparting your knowledge to those interested by your frequent travel to conduct workshops and training sessions is applaudable. Being an educationalist and a specialist in fetal medicine, obstetric USG, genetics, and gynecology, you have always proved that passion, perseverance, and sheer power of will can take one a long way. Your service to the building blocks of the future society, the fetus, and the unborn baby is an ideal in itself. We considered it an honor and privileged to present to you today late Dr. V.N. Shriodkar Oration Award 2022 for your oration on rhesus isoimmunization in pregnancy yesterday, today, and tomorrow. Dr. Aboli Velankar, President, Dr. Archana Shah, Secretary, Dr. Prajakta Shitore, Clinical Secretary, Dr. Sudeep Sambaram, Treasurer.
With the permission of the chair, I declare that the oration end here. It gives me immense pleasure to deliver the vote of thanks for V.N. Shriodkar oration. I would like to thank our orator, Dr. Chinmayi Ratha Madam, who honored this function with her inspirational thoughts. Thank you, Madam. I would like to thank our President, Dr. Aboli Velankar Madam, Dr. Archana Shah Madam, Dr. Sudeep, all the executive body members, all the SOGS members who have come here in large numbers today and making this oration the grand success. Thank you, Mr. Shedzae, for all the audio visuals. Thank you, Balaji Sarovar, for hosting this memorable Dr. V.N. Shriodkar oration. Thank you, Mr. Mohan, for photography. Thank you, Mr. Ivae, for all the help done. Thank you, everyone, once again. I invite you all to join the delicious lunch. Thank you.